once more with the Motley Fool, and I've been to a very crowded CES for 8 straight years now. And I can honestly say that there's one thing I'm seeing this year that I've never seen before, and that is one technology that's responsible for so much of the industries and the companies you see here today. That technology projected to be worth $17 trillion by the year 2035. Okay, maybe this sign gives it away. Or this one. Or this one. It seems everywhere I turned this year,
Hello, VJ. Can
Hello,
you hear
good
me?
morning, good afternoon, sir.
How are you?
Fine, sir, fine, thank you.
Okay, I'm John Bennett. Now, do you know how to screen share and everything?
Yes, sir.
Okay, want to go through that? Make sure everything's okay.
Sure, sir, sure.
Yeah, just
Am
go
I
through.
audible, sir?
Yeah, that's okay. It's
That's
all right.
okay.
I haven't started recording it.
Bennett.
Hey, Manas, how you doing?
Yeah, fine. How are you today?
Very good. Very good. I got to get serious here and put the serious background. Yeah, I know you like backgrounds too. Is a better one.
Yes.
Sir, good afternoon, sir.
Ready,
Okay. Yeah, you have the sky, huh?
Vijay? Yeah.
That's nice.
Where are you, sir?
I'm at home.
At home or at
I just changed the background. It looks like I'm outside.
Yeah, you are in the skies.
Yeah.
You are traveling by flight and you are organizing a webinar.
You can just, should you try the share screen and check it's working or not?
VJ, yeah, you feel comfortable, right?
Vijay can just try to share your screen and...
You're muted, VJ. You're muted. There you go. You can hear me, VJ, but we can't hear you because you're muted.
Vijay, your audio is muted.
Yeah, let me see if I can mute him here. I should be able to. Yeah, you can hear us, VJ, right?
Yeah, this is my screen, sir.
Okay.
Yeah.
Can you share your screen so that we check it's come. It's working. Yeah, so we can go back and then...
Yeah. Shall I close this?
Yeah.
Oh, well, go. Okay, whatever. If you feel comfortable, that's fine.
Hello?
Yeah, if you feel comfortable,
Yes.
unless you want to go through it, that's fine. Do you want to go through it again?
Yes, 1 second, sir. I'll just do that.
Yeah, just go through it and go through the slides and advancing the slides.
Yeah.
Put it on the full screen. Just like, okay, you put it on the big screen at the bottom. There you go. Okay, to advance it, you know how to advance it, right? Okay, you know how to do it. And you know how to get off it. Do you don't have any? Do you have any videos?
No, I don't have any videos.
Okay.
I'll speak on surgical steps at the end of my talk.
Okay. If you so you do have a video at the end, that's okay. But
yeah,
just so I know, and the sound and everything, you know how to control it, right? Okay. Generally, I like to start when I introduce you to be off the screen share. So I'm going to take you off the screen share there. Okay. I need you you need to stop the screen share, BJ. So when I introduce you, yeah, when I introduce you and everything. Okay. We just start that way. That way, you know, you see my face and your face rather than just someone in the corner. You've done these before, right, Vijay?
Yes, sir, I have done that.
Okay. So you're a veteran. Welcome, everybody. Any newcomers here? Roberto, good morning.
Hi, John. Hi, John.
How you doing? You got some fruit with you this morning, huh?
I'm a bit depressed. It's more than 2 months now. I'm stuck at home and
Well, you got fruit there with you. You got some fruit
man.
in the
Yes, some oranges
background.
behind.
Yes. I have oranges because I'm studying so much that I was meaning the juice of life.
Juice of life. Okay. Oh, you just, Robert, are you just tired of being cooped up? Oh, the screen froze. I think it did. Roberto, did your screen freeze?
Eh?
Did your screen freeze? No, I guess you dropped off.
No, it's going.
Oh, okay. Yeah, just waiting. It's no big deal. I mean, does anybody have any questions before we start? Like everyone knows, I think pretty well knows about the mute button. It's been pretty good. So just keep conscious when you share. That's you're welcome to share, but after click off the mute.
Hello?
Yes, hello.
Shall I start, sir?
I'm sorry.
Shall I start?
Three more minutes.
Oh yeah, a few more minutes.
Okay.
What was someone else going to start presenting? That's a surprise to me. Yeah, VJ will present, then after I guess we'll do questions, right, VJ?
Yes, sir.
Dr. VJ. What part of India from?
Can you come again, sir?
I'm sorry, what part of India?
Hyderabad.
Oh yeah,
Hyderabad. So-
Hyderabad.
Yeah, me, Vijay, Suchanda, all are from Hyderabad. So in 3 days from Hyderabad, all 3 days.
Yeah, it's a lot of people, a lot of neurosurgeons from there.
Yeah.
Okay, some more people coming. Yeah, Manas, you there?
Yeah.
Yeah,
Yes,
after
I'm here.
after you can moderate unless Ipe comes, okay?
Okay.
I don't know. I don't know if Ipe wants to moderate or not, but if not, then you know, because you can kind of tell the way the discussion is going better than me. Okay. Okay, let's start. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett, broadcasting for Neurosurgical TV. We have another episode of Daily Dose of Neurosurgery Education. And today we have the honor of having Dr. Vijay from Hyderabad. He's going to introduce himself and tell about himself and go into his presentation. Welcome, Vijay, and it's all yours. And thank you for coming.
Thank you, sir. Thank you. Good afternoon, my dear friends.
Okay,
Today I will be discussing the most important topic of neurosurgery, especially spine surgery, that is upper cervical spine injuries. I am Professor M. Vijay Sarathi, working in the Nizam Institute of Medical Sciences. I was ex-colleague of Dr. Manas. So to begin with the spinal instability, basically we have two theories. One is Holdsworth, who has divided the spinal column into two columns. One is anterior and posterior. And Dennis has classified into three columns: anterior, middle, and posterior. And we know that White and Punjabi has defined the stability and instability as the ability of the spine and the normal physiological loads to limit the patterns of displacement so as not to damage or irritate. That means spine and the normal physiological load should not create any pain or deformity or deficit. So what is so special about upper cervical spine? Injuries are not uncommon, that is, they're common injuries, but they are difficult to recognize by the fact that the CV junction area is covered anteriorly by the facial skeleton, laterally by the mastoids. If they are not recognized, they lead to disastrous consequences, and we have various treatment modalities to treat these spinal fractures. Coming to the symptoms of upper cervical spine trauma, you have classical 3Ds, that is deficit, deformity, and dolor, that is a pain. And the signs which are specific to the upper cervical spine trauma are lower cranial nerve palsies, dysphagia, probably because of lower cranial nerve palsies, or prevertebral hematoma, some special sign of C2 neuralgia, or maybe called a symptom. And sometimes patients may present with a posterior circulation stroke because of the vertebral artery dissection. So there are some consensus guidelines how you measure the measurements in the CV junction trauma. For example, suppose if you look at the occipital condyle fractures in the sagittal plane, this is how you draw the pattern of the measure of displacement from the base of the occipital condyle to the tip. That means this is the gap where there's a displacement of the fracture. And this is measured in terms of apposition, percentage of bone which is in contact with its parent bone. Same thing is true in the coronal plane, where you measure the displacement as well as opposition. This is how the measurements are drawn in the occipital condylar fractures. Coming to the measurements of the CV junction, you have these measurements. The Basal dense interval, you draw a point from the Basal tip of the odontoid, you draw a line, and also there is a Basal axis interval. You draw a line from the posterior surface of the axis, and you draw a line from the tip of the fibers. This is also measured. This is how you measure the various measurements of the CV junction, especially in case of trauma. Other most important the measurement is the odds ratio, where from the Basal you draw a line to the posterior arch of the atlas and opistheon to the tip of the dens. Other one is the lateral mass displacement. This particular measurement is especially useful in treating the Jefferson fractures, where you look at the lateral mass displacement, the displacement of the C1 lateral mass over the C2 lateral mass. For example, if this is X, and this is Y. X plus Y, if it is more than 6.9 millimeters, that indicates probably that transverse ligament is torn and where the indication of surgery lies. So when there is a displacement more than
Excuse me, VJ. We're gonna have to stop here because we're gonna have to figure out, try to improve the sound because your sound is breaking up. You have a smartphone with you?
yeah.
Okay, if you can, we can try entering the webcast with the smartphone just for the voice. In other words, turn your voice off on your desktop or laptop there and turn your voice on your smartphone on. So we get your audio from your smartphone. Do you know what I'm saying?
Yeah, I got it. Is it okay now?
Yeah, now it's good. Is it? Yeah, it's
Yeah,
good.
I'll continue like this.
Yeah, it's good. Okay.
Let me try this one.
Okay, carry on.
Sure. So another measurement in terms of Hangman fractures is a translation between the C2 and C3. You draw a line from the posterior border of the C3 and C2 and measure this distance. If this is more than 3.5 millimeter, it is supposed to be unstable. That means the ligaments are no longer in a capacity to hold it stable. Same thing is true with the C2-3 angulation, where you draw a line from the inferior part of the end plates and try to measure the angulation. If the angle is more than 11 degrees, that means ligaments have failed. They're no longer in a capacity to hold the spine stable. This is how you measure the displacement patterns in the odontoid fracture. You draw a line from the anterior part of the C2 body as well as the anterior part of the broken odontoid. You look at the displacement in terms of millimeters, and same thing is holds good with the angulation. All these things are very important in deciding the surgical therapy, whether you want to go anteriorly or posteriorly or whatever it may be. So coming to the occipito-atlantal fractures, these are very, very important. If you look at the joint of occipito-atlantal joint, this is very deep in the neck and very large force is required to destabilize this joint. For example, look at the occipital condyle, which is very robust structure. It is convex anterior-posteriorly and also from the side to side is a very big chunk of the bone which exactly fits into the C1 lateral mass. Look at the superior articular facet of the C1, which exactly is a key of the occipital condyle. So they exactly fit into each other. It's very large force is required to destabilize this joint. So the occipital condyle fractures are divided into three categories. Type 1, which are called as a burst fractures. Look at that, the entire occipital condyle has become into pieces. And type 2 is the fracture where the fracture line from the skull base extends to the occipital bone and gives rise to fracture here. This is type 2. And type 3 fracture is a fracture where the occipital condyle has got dislodged from the parent bone. This is where our surgical decision will come into picture. So rest 2, type 1 and type 2 are benign fractures which can be managed conservatively. So how do you treat these OC fractures, occipito-cervical fractures? What you need to ascertain is there any dislocation, dissociation between the occipito-cervical joint or not? If the dissociation, occipito-cervical dissociation has resulted out of the fracture, you need to perform the occipito-cervical fusion. If dissociation is absent, that means the occiput and cervical is still together. You can make the patient to wear hard cervical collar for 6 weeks and reassess him after 6 weeks. If he is doing well, all his symptoms of instability has come down, you can manage him conservatively. So how do you really account for the occipito-cervical dissociation? So basically there are 3 types of occipito-cervical dissociations. One is type 1, when the occipital condyle moves forwards, that is anteriorly in relation with the odontoid process or the C1 lateral mass, or type 2 when it has migrated superiorly, that is when the apical ligament is torn. It is something like distraction injury. and type 3 when the occipital condyle has moved posteriorly. So all these three patterns of occipito-cervical dissociations are possible in this particular area, and it is very pertinent on our part to identify these dislocations before we treat these patients. So this is what it looks. If you look at this, this is the occipital condyle and this is the C1 lateral mass. Both of them have got dissociated with each other. So the minimum gap, that is beyond 1 millimeter gap between these two, is supposed to be abnormal. Same way, this is if you measure the Harris measurements, that is a dense basion dense interval. If it is more than 12 millimeters, it indicates that probably there is a apical ligament injury. Same thing if the Bayesian axis interval, if it is also more than 12 millimeters, that is, there is a loss in the cranio-cervical relations, and you should suspect the occipito-cervical dissociation. Same thing is true with the Powers ratio, where the Bayesian, a line drawn from the Bayesian to the posterior arch of atlas, and a line drawn from the opistheon to the tip of the dens. Normally, there the ratio is 1. If it is more than 1 or less than 0.8, that indicates that there is a imminent or existing occipito-cervical dissociation, which mandates occipito-cervical fusion. So Lendl has classified the Atlantic fractures into type 1, type 2, and type 3. Type 1 are those fractures where the fractures are either anterior or posterior to the lateral masses. Usually they are called plow fractures. They are stable fractures usually. And type 2 fractures are the fractures there where the fractures will be lying both anteriorly and posteriorly to the lateral masses. This is typical of a Jefferson fracture. Here you find a fracture line anteriorly and posteriorly on one side. Here is a fracture line anteriorly and posteriorly on the diagonal sides. And third type of fractures is that a comminuted fractures of the C1 lateral mass. And fourth one is the linear fractures of the C1 lateral mass. So this type 3 can be managed conservatively. And what we need to look at the type 2 fractures where they may require the surgical intervention. So coming to transverse atlantal ligament, the class Dickman, Curtis Dickman from Barrow Neurological Institute has classified these fractures. The transverse atlantal ligamental injuries are type 1 or type 2. Type 1 injuries is the injury. The transverse atlantal ligament has been cut either at the center or at the periphery. In both these circumstances, when there is a complete loss of integrity of transverse atlantal ligament, surgery is the only answer. If the transverse atlantal ligament is because of the bony avulsion, in these cases the halo or conservative treatment may improve, maybe become successful. So when you look at this Jefferson fracture, where there is a C1 lateral mass and which is getting apart, that means that this is where you need to measure the lateral mass displacement. This is if this and this, if you add this, if it is more than 6.9, that is most likely the transverse atlantal ligament is torn. When you look at this, you can find that the occipital condyles are descending down. That means that there is some amount of cranial settling happening because of the Jefferson fractures. When you take the atlas, these red lines indicate that these are the fracture lines of the Jefferson fractures. This orange line indicates fractures of the lateral masses. This green line indicates the transverse atlantal ligament injury. This blue line indicates the transverse atlantal injury because of the bony avulsion. So Jefferson fractures were almost described almost 100 years ago by G. Jefferson. He published his case series of 4 cases, autopsy studies in British Journal of Surgery in 1970. He could conclude that these fractures are resulting from the axial compression, and there is severe dislodgement of the lateral masses in all these cases. And also he could demonstrate that the transverse atlantal ligament in these patients were badly torn. So in this, again, this case, this is the lateral mass displacement. This plus this is around 6.9, which indicates the transverse atlantal ligament is gone. I'm repeating repeatedly because this is a very important point to advocate surgery for these patients. Suppose in this case, probably the lateral mass displacement is more than 6.9. The only we look at this, when there is later transverse atlantal ligament is torn, the procedure of choice in these patients would be C1, C2 fusion, irrespective of the fusion method you adopt, the transarticular screw or C1, C2 screw, whatever may be the translaminar screw, whatever said and done, the treatment of choice when there is a transverse
Excuse
atlantal
me,
ligament.
excuse me, Vijay, we're breaking up again. Is there anything you're doing different? We're breaking up a lot again. Okay, so just make adjustments, okay? Okay, let's try again. Keep going, just
Yeah.
adjust.
Yeah, is it okay now, sir?
Yes, it's okay now.
Yeah. If the transverse atlantal ligament is broken, the treatment of choice would be C1, C2 fixation, irrespective of the fixation method. So coming to this aspect of the Jefferson fracture, where the lateral mass displacement is not less than 6.9 and the transverse atlantal ligament is not torn. In those situations, probably people still perform the C1 lateral screws with a connector, and they tend to compress both the screws so that these two fragments come and oppose to each other, so that there will be a fusion. This is what the X-ray looks like after both the transverse, the C1 lateral mass are brought together. So coming to rule of Spence, there is a recent article by Wood et al. In 2018 Neurosurgery. They say that it is not 6.9, so-called the rule of Spence is not an absolute number. Sometimes you may find the transverse atlantal ligament broken when there is a lateral mass displacement is less than 6.9, even at the range of 3.2 millimeters. That means the transverse atlantal ligament integrity should be confirmed by the MRI scan and in order to decide about the surgery. Coming to the atlas fracture, let us look at the algorithm. Suppose if the atlas fractures are combined with the C2 fractures, the treatment guidelines has to be done as per the C2 fracture. Suppose if there is a disruption of transverse atlantal ligament, and if there is a type 1, the non-bony avulsion, straight away you have to go for C1, C2 fusion. Suppose if it is type 2, bony avulsion, you can try conservative treatment with a halo brace, and again at the end of 3 months you can do a flexion extension X-ray, and if it is unstable you can go for fusion. Coming to these fractures where transverse atlantal ligament is intact, that means lateral mass displacement is less than 6.9, all these patients can be managed with the cervical collar for 3 months, and again you have to follow them up. Coming to odontoid fractures, they are the most common fractures of the upper cervical spine. Type 2 odontoid fractures are the most common fractures, and if not untreated, there is 100% non-union in these patients because the paucity of the blood supply at the base of the odontoid process where the actual fracture site. The differential diagnosis of the type 2 odontoid fractures is one ossiculum terminale. Morphologically, it is a smaller segment lying at the apex. And second one is the os odontoideum. The features by which you can differentiate os odontoideum from the type 2 odontoid fracture, that you have a clue, that is the anterior arch hypertrophy, that being a congenital in nature. And this particular fragment will be above the interjoint line of C1, C2. And this has a smooth margin contrary to the type 2 odontoid fracture, which has a ragged margins. This is how you will differentiate between the os odontoideum and the type 2 odontoid fracture. So how much force is required to fracture a spine? Generally, we think we need lots of force is required to fracture a spine. Here is a case where this patient had a trivial fall and became quadriplegic. When you look at this, entire spine is fused. When he fell down, the force which was generated at the lower spine has come to the upper spine, and it has become many-fold. That is what is called cantilevering effect. That has resulted in the fracture of the C3-4, and he became quadriplegic. Suppose if there is a fusion of this particular spine also, as you find in this case, the only thing left to be fractured is the odontoid process. So odontoid fractures is most common fractures in the patients, elderly patients who are suffering from diffuse idiopathic skeletal hyperostosis, where the most of the spine is fused. Here, the non-halo treatments always fail in the geriatric population. Of course, they cannot tolerate the halo fixation in view of the lung compliance issues, and hence surgery has shown consistently better, that is C1, C2 fixation in all geriatric type 2 odontoid fractures in terms of reducing the morbidity and mortality. So initially, when type 2 odontoid fractures, the anterior odontoid screw, when it was introduced in 1990s, it was very huge welcome for that surgery, with reported rate of 90% fusion rates. But over a period of time, people have observed the obstacles in terms of age, poor bone quality, and a fracture type which is anterior inferior type, and a people coming too late to the treatment. So there are certain factors, good factors for the treatment success, that patient should have a healthy bone. There should not be any deformity of the fracture. The subaxial spine should be mobile. Patient should be thin, because thick patient, the trajectory of the screw passage will be difficult. So what are the red flags in doing the odontoid screw fixation, that's anterior screw fixation? Suppose if the gap is more than 3 millimeters and lateral translocation, more than 5 degrees of angulation, more than 1 degree of lateral tilt, some end pass, bony cyst, Klippel field anomaly, all these factors will tell us that this patient is not a suitable candidate for the anterior odontoid screw fixation, which is supposed to preserve the rotation in all the cases. So what is the literature for that, literature evidence for the treatment of odontoid fractures? Evidence is poor, and if you miss the injury, there is going to be 100% non-union, and halo, invariably halo treatment fails. And almost the reported non-union rate of almost 15 to 85% in various series. And even with the successful fusion with the anterior odontoid screw, there is 30% reduction in the rotation in the long-term follow-up. So most important criteria in deciding when you are going to perform the anterior odontoid screw is the two most important things. One is the intact transverse atlantal ligament, and second one is the ability of the surgeon to reduce distal fragment in line with the screw passage. This is very, very, very important. In case if these two things are not met, there is no point you can do the anterior screw fixation. So the ideal patient would be a thin patient with a healthy bone, with a fracture type of anterior superior posterior inferior type, undisplaced, unangulated, and fresh and non-deformed axis. So this is how the anterior odontoid, all of you know about this. There's nothing more I can tell about that. So this patient, initially, we performed the odontoid screw, and initial X-ray looked okay, but patient went home and came back with the persisting worsening atlantoaxial dislocation. The screw has broken, that it has cut through the anterior surface of the C2 body. Probably screw trajectory was too superficial, so this has to be revised again. In the CT scan, you see that it has resulted in the C2 fracture. So the patient, again, we had to remove the screw, and we had to perform the posterior C1, C3 fixation. So you should be very careful in deciding the screw trajectory. Once we miss the screw trajectory, entire surgery will be big mess. Coming to Hangman fractures, very important fractures. So you have type 1, type 2, and type 2A, and type 3. Type 3 are highly unstable. Type 2 is intermediate stable, and type 1 are stable. These can be managed conservatively. So how do you measure the, how do you estimate the instability in Hangman fractures? If you find the displacement more than 3.5 millimeters or the angulation more than 11 degrees, that indicates this particular Hangman fracture requires surgical fixation, either anteriorly or posteriorly. Look at this case. This case is a type 3 Hangman fracture with a gross subluxation and rotation. When the MRI is taken, you can see that C2-3 subluxation, gross subluxation, and the disc is collapsed. The posterior superior part of the C3 is impinging upon the cord. So here options are: conservative treatment is ruled out. Halo treatment, yes, but halo may not maintain the reduction after having achieved it. And surgery is only option, either anterior or posterior or a global fixation. So this is what we have performed. We performed a single anterior fixation from C2 to C3, and also we included a C4 to have a long cantilever in order to reduce this fragment. So this will result in the beautiful fusion within 3 months of the entire the fracture site as well as the grafted area. This results in a very stable fixation at the end of 3 months. So this is what the technique is of reduction of the high-grade spondylolisthesis, the high-grade Hangman fractures. This is, we call it as sequential tightening of screws. You place a plate over the C2 and C4, engage the screws, and once you partially engage C2 and C4 and put a screw into C3 with a gradual tightening of the screw, entire C3 can be pulled up. So this is what the intraoperative pictures, and this is at the end of immediate post-operatively, we have this fracture here, and this is a graft here, and at the end of 6 months later, this is a beautiful fusion. You can see both at the grafted area as well as the fracture site. So what is the anatomy? Let me just one slide about anatomy of the Hangman fracture. The pars fracture is because of the hyperextension, and the distraction and hyperflexion will cause a disc fracture and also dislocation of the fragments. And basically you have two segments. One is a cranioventral. This is the cranioventral segment of the Hangman, and the dorsocaudal segment of the Hangman. These are two fracture fragments which have to be fused with the surgical manipulation. Normally, the gravity passes through the C1 lateral mass, comes to the C2 lateral mass, goes to the pars and goes down along the facets and comes in front and goes down into the C4. Normally, 80% of the weight is passed through in this way in the normal circumstances. When this fracture happens, with the fusion anteriorly, we are going to place a graft here and we are going to fuse here, so that the entire the gravity is shifted here, and this is put to rest, and so that this can heal gradually. So this is a typical case of a type 2A Hangman fracture with a minimal subluxation, minimal angulation. There is definitely disc space injury and anterior longitudinal ligament tear. So this requires anterior fixation, C2-3 plating with the C2-3 discectomy and fusion. These are the steps where you put a plate in, put a screws into C2 and C3 and put a graft in between the C2 and C3. So this is another case, high-grade Hangman fracture, where there is a severe subluxation, huge gap, huge prolapse of C2 over the C3, and this patient was put on traction. There is almost reduction of the fracture fragment. Now the option in front of us is either to go anteriorly or posteriorly. And after so many deliberations, one of us, we wanted to go posteriorly, but once we passed the screw, this was the result. So the fragment has moved forwards instead of coming back. So, what are the red flags to put a screw of the pars? At what circumstances you end up doing like this? So one of the literature surveys says that the permissible gap which of the fracture which allows the posterior screw to be passed is around 2.5 to 3 millimeters. So loss of or tear of anterior longitudinal ligament is also a factor which you should take into consideration to not to go from back to put a pass through in order to avoid disastrous consequences. So advantages of anterior approaches are, one, we can address the pathology directly. Here we are only tackling or fusing the C2, C3, where the preserves the C1, C2 rotation. You can very well maintain the lordosis by simple maneuvers like putting a lordotic curve to the plate, and you have a large fusion area between the C2 and C3. So of course, posterior approaches have their own inherent disadvantage of prone position. And if the gap of the pass is more than 3 millimeters, we cannot put the pass screw, and you end up doing C1 and C3, which limits the rotation. Of course, our friend vertebral artery is always a hazardous doing in posterior procedures, and extensive muscle dissection is required. And of course, there will be a restriction of rotation. In the previous case, again, we had to remove the hardware, and we went anteriorly and fused from the C2 to C4. And this is the result of in the post-operative MRI, shows a beautiful realignment of the cervical spine with the surgery. So halo complications are pin related. A lot of issues in the chest expansion, especially countries like India where temperature is high. Many people refuse to wear the halo fixation. So in these halo fixation in the highly unstable fractures, the non-fusion rates are ranging from 20 to 70%. So halo is a very limited role in the in patients where the established instability is there in the CV junction area. Coming to C2 fractures, these fractures are non-odontoid, non-Hangman fractures, which comprise of 20% of all cervical spine fractures and around 1/10 of upper cervical spine injuries. All of us know that C2 body is the region which is lying below the odontoid process in between the two parts interarticularis on both sides. So here is a 32-year-old male patient who presented with a road traffic accident followed by pain and restriction of neck movements. He has no neurological deficits. This is a fracture. This is neither Hangman nor odontoid type 3. So in the axial section, you find the sagittal split of the C2 body. These patients generally going for surgery is the better option because they can go back to the work very early. So in this case, the treatment options are conservative, halo. As I said, halo has its own inherent problems. Surgery is an anterior or posterior. So in 1933, Starr et al. Reported 6 atypical Hangman fractures. They named them as the atypical Hangman fractures, which were actually supposed to be the fractures of the axis body. So Benzel again, he classified these axis fractures into 3 varieties. One is coronal fracture, sagittal, horizontal. Let me take you to this picture. This is type 1. There is a fracture line in the coronal plane, which splits the body into 2 coronal halves, one half in front, one half in the back. The half is there in the front. It can come forward. This is type 3, which is almost similar to the type 3 odontoid. This is type 2 Benzel fracture, which splits the axis into 2 equal halves. Hello?
Yes, the sound is breaking up pretty significantly. Yeah, could you just move or do whatever?
Yeah, just give me some time.
Yeah, okay. No, everybody realizes the challenges. Ready to start again?
Yeah.
Okay.
So Fujimura has classified these fractures into 4 types. One is avulsion fractures and horizontal fractures and burst fractures and sagittal fractures in order to classify them into 4 groups. Coming to the literature of the C2 fractures, we have very sparse literature and suggested treatments are many. Many people suggested non-operative treatment as a primary therapy for the C2 fractures in all majority of previous studies. And there is no class 1 evidence for the management of C2 body fractures. So certain cases, definitely these fractures require the surgical management. So the consensus regarding the surgical indications in these fractures are fractures which are associated with the instability of adjacent joints, and unstable type 1 Basal fracture where the large fragment in front comes forwards, and the fractures which results in the spinal cord compression, and if there is a fracture which goes and disrupts the superior articular facet of the C2. All these fractures, they require surgical stabilization. So this is typical case of type 2 sagittal split, which patient, we advise the patient to have a halo because this is supposed to have this. When you look at the MRI, there is a lot of ligamental injury. So patient wanted surgery. So this patient was treated with the posterior C1, C3 fixation. This is another type 2 Basal fracture where there's a combination of the C2 vertebral body, and this patient basically also was treated with the posterior C1, C3 fixation because we cannot put screw into the fractured vertebral body. This is another case of a Basal type 1 where there is a sagittal fracture here where the C2 body has fractured and had a propulsed in front, and this is also supposed to be unstable fracture where this fracture was treated with the anterior cervical fixation from C2 to C3. Another comminuted fracture of C2 where you can see the body fragments of C2. This patient doesn't really, conserving this sort of patients is hazardous because of a large amount of comminuted fracture. So this patient has a long neck. We performed anterior C1 to C3 fixation with the screw part into the last segment of the bone in order to keep it in alignment with the rest of the spine. Basal type 1 fracture, this is Basal type 1 fracture, where there is a large fragment in front getting coming out of the C3 body, and this patient as well had a transverse atlantal ligament injury. That means it required C1 C2 fusion. So this patient underwent C2-3 anteriorly in order to give a blood first to this particular C2 large fragment and followed by C1 C2 fixation. Another neglected C2 fracture where patient has come to us very late and patient had neurological deficits. This patient, we put him on traction. Once there is a reasonable reduction, we had to perform C2 carpectomy, put a cage, and did a C1 to C4 anterior fixation. We had to use a larger cantilever because this was is a highly unstable fracture. So C2 fractures, what is the best method of treatment? Still, it is under debate. Management of C2 body fractures should be individualized, and many of them can be managed conservatively. However, with the recent advancing in the imaging where you can look at each and every corner of C1, C2 complex, the surgical indications are becoming more and more. So to summarize, the summary of surgical decisions are like this. Suppose if there is an occipito-cervical dissociation, you look occipito-cervical fractures, you look at the dissociation between the cranio-cervical dissociation. If dissociation is present, they are the candidates for the surgical fixation, that is occipito-cervical fusion. In the C1 fractures, the most important concern is the transverse atlantal ligamental integrity. If transverse atlantal ligamental integrity is present, you can conserve them. If transverse atlantal ligament is torn, the C1, C2 fixation has to be performed. Coming to odontoid fractures, the only indication for the anterior surgery is the presence of transverse atlantal ligament in normal transverse atlantal ligament. In case transverse atlantal ligament is torn, the management should be C1, C2 fixation, posterior C1, C2 fixation. Coming to Hangman fractures, most of these fractures can be managed by anterior surgery. It has more direct exposure to the fracture site. This can be debrided thoroughly. A large fusion area for the graft can be kept there. So most of the patient, there's no blood loss, no muscle dissection. So C2 fractures have to be individualized. So these are the, and if there is a combined fracture of C1, C2, all these fractures have to be managed as per the guidelines of the C2 fracture. So these are my summary of my talk, that is right ranging from the occipito-cervical fractures to the C2 fractures and combined fractures.
Okay, thank you very much. Okay, Manas, are you there? Manas, are you there? Or perhaps he isn't. Okay, let me get you off screen share there. And we'll open it up for comments or questions. Okay. Well, there's Manas. How you? Okay, why don't you introduce yourself, Manas, and take over, please.
I'm Manas Panigrahi. I work as a neurosurgeon at Hyderabad, India, and thank you, Dr. Vijay, for giving a clear concept of how to manage trauma of the upper cervical spine. I see Dr. Atul Goyal online. I'll request Professor Atul Goyal to give some comments. There is one question from Dr. Raghuram. He has asked, is there a role of surgery for type 2B odontoid fractures?
Type 2B odontoid fractures, the indications remain the same. Presence of transverse atlantal ligament should be normal, and the fracture fragment has to be in alignment with the axis. The major problem with the type 2 is the inability of the surgeon to engage the distal fragment. Most of the time you end up doing C1, C2 posteriorly. Hello?
Yes.
Yeah, thank you. Thank you. There's another question. What is the protocol to follow in cases of upper cervical spine injuries associated with cord edema?
So if there is a cord injury, that means all fractures are unstable. The moment you find upper cervical spine injury in the CT scan or MRI, immediately they have to be put on cervical traction, and based on the available guidelines, the treatment option should be offered. Most of the patients where cord injury is there, most of them are almost 100% are unstable fractures. The only contraindication for the putting traction is the occipito-cervical dissociation. So if you rule out the occipito-cervical dissociation, all other patients can be put on cervical traction, and they have to be managed surgically in case there is a cord injury.
Is it possible to approach C1 through the anterior approach for fixation?
Yeah, it's very difficult in those patients where there is a long neck, where in preoperative CT shows that the mandibular line is high up, where preoperative CT will tell us whether you will be able to reach C1 intraoperatively or not. If patient has a thick neck or obese patients, it's very difficult for us to reach the anteriorly C1.
Do you use steroids for any role of steroids for all these trauma injuries?
Steroids, most of the upper cervical spine injuries, they do not have any, they do not have cord injury because they make the space capacious. So in case there is a cord injury, the guidelines remain the same as rest of the body.
Yeah. There's a question that how do you measure the 6.9 millimeter to decide it is instability or not? Can they want to can you explain again?
Yeah, in the CT, in the coronal sections where you see both the C1 and C2 joints, and in the CT itself, in the gantry, we can measure in millimeters. But nowadays, we follow, apart from that, the MRI is more sensitive for the transverse atlantal ligamental injury than this particular, this one.
Yeah, the CT is an indirect evidence, MRI gives a direct evidence.
Yes, sir. Yes, sir.
Yeah. Dr. Erico has asked that what should be done if the patient has a red flag in
posterior C1, C2 fixation.
yes. Any problem?
No, let me just connect the charger to my laptop, sir. Just
Okay. How much of weight you use for traction and what is the ideal weight? As Dr. Vijay has some problem with the audio, in the meantime, I'll ask Professor Atul Goyal to give few comments. Professor Atul Goyal is online.
Yeah, Manas, can you hear me?
Yeah, I can hear you.
No,
can you give some management protocol, what you follow in upper cervical spine injuries?
See, upper cervical injuries can be quite complex and quite variable in their, site of injury, the extent of injury, the kind of dislocation, the kind of deformities that can happen, as has been very beautifully explained by Dr. Vijay. The issue is, what happens is when there is a fracture and significantly unstable, like Hangman fracture, like Jefferson fracture, Odontoid fracture, the most important thing that we have to identify is the region unstable? And more often than not, it is unstable, except for situation where it is odontoid tip fracture and here and there. Otherwise, in majority of instances, it is unstable and stabilization is the treatment. I know many people like to do trans-cervical odontoid fixation like Dr. Vijay was showing, and anterior cervical fixation, plate and multi-level fixation. I do not like anterior cervical surgery at all for this situation because one is that I am very familiar with the posterior techniques of fixation. And the second thing is all the muscles of the spine are located posteriorly. Anteriorly, there is no muscle except for longus colli, which is just a thin layer of muscle. Otherwise, there is no muscle anteriorly. So all the movements are actually regulated from behind. And if you have to stabilize, you have to first disconnect all the muscles which are going to make all the movements. And because all the movements are being regulated from behind, I like to do all my cases from behind. I know there are many people who like to do from front and multi-level fixation, as you have seen. But my feeling is, and I'm quite convinced with what I feel, is if you do any kind of fixation, the muscles of the posterior muscles of the cervical spine, which are like huge. The C2 spinous process muscle is a huge muscle. And if that muscle is not demolished, that movement that muscle will create has the potential to destabilize any kind of implant that is made from front. Despite saying that, I know many people, particularly orthopedic people, are very conversant and very happy with doing from front. But that is my point of view. And I was very happy to see a confident Vijay speaking about various things. And I am sure that he's doing a fantastic work.
So this, if the muscles are not detached, from either the insertion or the origin, and then we work from the front, is it not that the muscles will act better post-operatively? The functions will be more preserved because we're doing from posteriorly, we are detaching and then again attaching. So is it not more physiological?
Yes.
For
Let me just tell you what is the main biomechanics. See,
Yes.
when we stabilize, our implant goes from C2 to C3, or from C1 to C2, or C1 to C3. The aim, the success of that operation will be gauged by the complete stabilization. Means there will be no movement in that region. That will be success. Means it is fused. Fusion is the aim of surgery. You agree with that?
Yes.
Now that fusion, the problem is the muscles which are behind have so much power. You know when you open the C2 from behind, the muscles are like not exactly like, they are huge muscles, and they keep on giving traction to that area, and that fusion may not be allowed. So your fusion, there is a possibility of failure. That is what I'm saying of your implant.
Okay. There is a question from Dr. Musa. He's asked, when do you consider occipito-cervical fusion in cervical fractures? To Dr. Vijay. Dr. Vijay, you are with us? Dr. Vijay Sathi? Can you hear us?
Can you just repeat the question, sir?
Yeah. When do you consider occipito-cervical fusion in cervical fractures?
Generally, occipito-cervical fusion has to be avoided unless there is an occipito-cervical dissociation. Like, for example, if there is a fracture of occipital condyle leading to fixation, that's the only time when we can fuse from the to the occipital. Rest of the times, the C1, you can limit our fixation to the C1 itself. The only indication where you involve the occiput is the occipito-cervical dissociation, or a comminuted fracture of the C1 mass, which is painful and also associated with the occipital condylar fracture, which is displaced too grossly.
Yeah. Dr. Harsh Shah has asked how much weight you use for traction. Can you explain depending on the level? The weight used for traction. Vijay, can you hear us?
Yeah, I can hear you. Basically, all upper cervicals, we start with the 2 kgs minimum weight, and gradually increase by 2 kgs per day till it is reduced, or 2 lbs per level. Maximum, most of the times we can reduce by within 6 kilograms of weight.
Yeah, basically it's 2 kgs per body, and it should not be more than that. If it's the C3 is fractured, not more than 6 kgs.
Yes.
There's a question by Dr. Musa. Dr. Gupta has asked what screw you use for dense fracture. Can we use lag screws?
Yes, cannulated lag screw is the ideal one, where it can pull the distal fragment towards the base. Cannulated lag screw is the ideal one to be used for the odontoid fracture. Ultimately, still the principle of surgery remains the same, that the transverse alignment has to be intact while putting an anterior odontoid screw.
Yeah, so the ideal screw is a cannulated lag screw, and if you do not have, then you can use a a normal screw lag. But the cannulated lag screw is the ideal screw for getting the apposition, so that the fusion is better.
Apposition. Yeah.
Atul Goyal, any other comments from your side, sir?
Regarding the issue of occipito-cervical fixation, when to include the occipital bone in the fixation construct, that was one question.
Yes.
Yeah, I was discussing the other day, the occipito-cervical, occipito-atlantal joint is the most stable joint of the body, most stable. You go to the cadaver and take an axe and try to break the occipito-atlantal joint. or take a very sharp knife and try to break the ligaments attached to the occipito-atlantal joint, it will be extremely difficult for you to open that joint because it is such a strong joint. And that joint is meant to hold the head throughout the human being's life. On the other hand, atlantoaxial joint is the most mobile joint of the body. Craniovertebral junction instability for me means atlantoaxial instability. Craniovertebral junction stabilization for me means atlantoaxial stabilization. I do not include occipital bone in the fixation construct in any case, unless and until it is a huge trauma where the occipito-atlantal disruption has occurred. But in my entire experience for so many years, I have never encountered that kind of trauma. Even in pediatric cases, syndromic cases, there can be multi-level, multi-segmental spinal instability, like in Morque's disease, in Down syndrome, in various other syndromes. But occipito-atlantal instability will be never seen. That is my experience in that. So inclusion of the occipital bone in the fixation construct, according to my understanding, is extremely rarely required, if at all.
Thank you, Professor Goel. There's another question for Dr. Vijay. What specific MR sequence you ask for looking at the integrity of the transverse atlantal ligament? Shall I repeat? We cannot hear you.
You have to
Vijay, we
unmute,
can.
Vijay.
The question is which MR sequence? Usually
Yes.
the gradient echo 1 millimeter slices would be sufficient enough to look at the transverse atlantal ligament integrity. Gradient echo.
Okay. Thank you, Dr. Vijay. And then we are in right time for the next lecture by Professor Goel. So over to Professor Goel for to start off his lecture.
Thank you, Manas, thank you. John,
Yeah, I'm here.
would you like to begin?
Oh, okay. Yeah, okay. Yeah, hi, this is Dr. John Bennett from Miami Beach, home of Neurosurgical TV. We go on to the next presentation for Dr. Atul Goel. Without further ado, I'll let Dr. Goel take over. Welcome, Dr. Goel, and thank you. Okay, Dr. Goel, can you hear me okay?
Yes, yes. I have to warn you that for some time, for the next 7-8 minutes, my internet will be weak. Did you hear that, John?
Yes, yes.
So for till about 6, maybe 6:05 or 6:07, my internet might be weak. So please bear with me.
Okay, well, let's give it a shot.
Okay. So I'm going to talk to you on one of my very, very fantastic subject, and that is petroclival meningiomas. And it is my great honor and great pleasure to talk to all of you. I know many of you are quite young residents and young consultants, and I want to give you my journey on petroclival meningiomas. Petroclival meningiomas are one of the favorite tumors for skull-based surgeons. Whether it's favorite or not favorite, that is not the question. The question is, it is one of the more difficult neurosurgical problems. And I will say it is one of the most difficult neurosurgical issues in the entire subject of neurosurgery. Petroclival meningiomas were not even operated about 30 years ago. Very rarely, they were not even understood what is petroclival meningioma. So petroclival meningioma, this is the petrous bone, and this is the clivus bone. Like suprasellar meningiomas, you have tuberculum celli, planum sphenoidal, diaphragm celli. Similarly, petroclival meningiomas, there are various other, just a minute, please. Like petroclival meningiomas, there are various other structures in the vicinity. One is the tentorium. Many of these petroclival meningiomas are having a attachment to the tentorium. The second thing is, being petrous apex, many of these tumors can go in the cavernous sinus. In the petrous apex, there is petrous carotid artery. And just lateral to the petrous carotid artery in this area is the cavernous sinus. So many of the petroclival meningiomas go into the middle fossa in this area. Some of them go into the cavernous sinus. Many of them are attached to the tentorium. The basic premise is, here is the internal aortic canal. So there is 7th, 8th nerve here. Here is the Meckel's cave and the trigeminal nerve. So the tumor arising medial to the trigeminal nerve, or a little bit in the vicinity of the trigeminal nerve and going into the petroclival area, these are the petroclival meningiomas. And these meningiomas have troubled the neurosurgeons for over several years. More importantly, they have been understood only recently. And the surgery has really, skull-based surgery as a field has been defined and designed and progressed and established in the last 30, 35 years. So I will show you my journey with these tumors. More important is that these tumors can be of various kinds. They can be small tumors and they can be huge tumors. In the petroclival area, petroclival area means they have attachment to the bone and to the clivus. That is the bottom line. And then they extend to the cavernous sinus, lateral in the petrous bone, more lateral in the petrous bone. You can imagine more lateral in the petrous bone, easier it is. More medial in relationship to the basilar artery, more difficult it is. And many of these tumors are attached more to the clivus and the 6th cranial nerve, which is going in the from the pontomedullary junction and having a course in the clival dura here in this area, has a very close relationship to the petroclival meningioma, and that nerve comes into danger. And the second and most important thing that comes into danger is the basilar artery and its perforators. So it's a complex tumor and a very dangerous tumor, and you have to have quite a huge experience to be able to operate on these tumors, as you can imagine. More importantly, these are meningiomas, are benign tumors, and I was talking to you about meningiomas the other day. Most important is that we have to do a radical surgery, but radical surgery does not mean that we have to compromise on the integrity of blood vessels. Any small damage to the perforators of the basilar artery will make hemiplegia. Not only basilar artery, posterior cerebral artery is in big connection with the tumor in this area. Posterior cerebral artery is in big contact with the dome of the tumor, even in these cases. This case, of course, the PCA will be quite heavily attached. Not only that, the most important thing is the integrity of the other cranial nerves in the vicinity. More lateral it goes, it has a relationship with the nerves of the internal aortic meatus. So I will take you to a world of petroclival meningiomas. So many of these tumors in the petroclival area go into the cavernous sinus. How much tumor in the cavernous sinus to be removed Whether to remove the tumor in the cavernous sinus is a subject of great debate. And I will like to answer some of these questions. Many of these tumors go beyond the cavernous sinus in the petroclival, in the temporal brain, and many of these tumors come into the CP angle. These tumors can be of various kinds, as we all know, like meningiomas. I was talking to you the other day, they are like fingerprints, and all meningiomas are of different character, different consistency, different extension, different kind of histopathology, and different kind of mitotic activity, and all these things make the meningioma surgery different in every case. So you have to gauge as a surgeon when the person comes to you as to whether you would like to operate and what is the kind of approach that you will like to do. You see, this is another very formidable kind of tumor with multiple ragged edges and calcification and encasement. When there is calcification, I mentioned to you the other day, more often these tumors are more benign meningiomas. Soft tumors encase the arteries. Firm tumors displace the arteries. Soft tumors are more vascular. Firm tumors are less vascular. Firm tumors are more benign. Firm tumors are long-standing. The history may be very long-standing, but presence of a firm tumor like calcification and vascular encasement makes this tumor an impossible surgical procedure. Tumor going from one side to the other side, of course, these are very, very uncommon tumor. Just for the sake of showing, I'm showing you this tumor. But you see, even in this case, there is a lot of calcification and extension on both cavernous sinus. How much to remove, what to remove, and what not to remove will be a question. And whether to remove, whether your surgery can harm the person. As I have my main message to you will be, we are all neurosurgeons, but we have to be technically fantastic. We have to be technologically fantastic, but we have to be human first. We have to know our limitations, and we have to know the strengths of the tumor and the weakness of the tumor. Like in this case, if you see there are some necrotic areas, and this tumor has some vascular encasement, but softness will be, this tumor may be relatively straightforward. So you have to know before operation on the basis of presenting clinical features presenting for, if the clinical features are for 10 years, means the tumor, the relationship of the brainstem is for 10 years. So that tumor will be more difficult. If the presenting symptoms are for 1 month, the relationship of the brainstem with the tumor is not such a long brainstem, such a long relationship. So longer the relationship, more intense is the relationship. If I'm your friend for 20 years, my friendship with you is for stronger. If my friendship is for 1 month, only you do not know, my friendship is very weak with you. Similarly, if the tumor is for 10 years, the friendship with these blood vessels is quite intense. And that friendship we have to break. So it is difficult to break that friendship. On the other hand, 1 month friendship can be relatively easier to break. So these tumors can go into the middle fossa, go into the cavernous sinus, can go into the CP angle, can go across the midline. So this is a different tumor. This is another tumor. You see how this is going in the middle fossa, involving the posterior circulation, involving the internal carotid artery, and having quite an intense relationship with the structures of the brainstem. More important for us will be identification of the relationship with the basilar artery. This tumor is right in the middle of the clivus and going in eccentrically on one side. This is another tumor. You see the extent of brainstem edema that you can, cerebellar edema that you see. So what I'm trying to say is every tumor is of a different character. And by using our understanding of the subject of neurosurgery, you see there is attachment here in the petrous apex, and the tumor is tumor is going in the cavernous sinus and beyond the cavernous sinus, encasing the internal carotid artery.
Okay. Okay, we have to do the Goel bop. We just wait. We just wait this stoppage out. So get up, stretch your legs, walk around. Should be back shortly. Just wait, everybody.
John,
Yes.
yeah, some people are saying they can't join the panel. Do we have a limit on how many people can join?
Yeah, 100.
Oh, okay. Sorry, we're past 100 then.
Yeah, we're past 100, and well, it goes and comes, but right now it's, but I'm learning this now. But the people that cannot come in can still watch and they can chat.
Oh, okay. All right.
So I'm learning that. You see the column?
Okay.
Do you see the column on your screen of people?
No, I'm in. Some of my friends are telling me that. Yes.
Yeah. I can't let them in after, because I talked to support a few minutes ago, which they're very difficult to get a hold of. You can imagine. But I waited for 60 people in front of me, and they said basically I can have 100 panelists. And I asked if you could get more. They said no, but you can have attendees that can see, and they can ask questions, they can chat, and I can promote them to the panel if I have less than 100. So.
All right. Okay.
That's a long explanation you probably didn't want to hear. Okay, we'll just wait for Dr. Goel. He'll come back. It's like he always does. Hey, do you know the names of the people who are trying to get in? So I'll see. I can see the names here. Richard, Peter, Houston, Manakan, Irfan, Alamed. Man, are those names familiar? You're muted there. You're muted there.
Oh, I think it's quite a number of people. It's a group. Yeah.
Okay, tell me that. Okay, we go up and down with 100. What are their names? I'll let them in. I can see them.
All right.
Especially if you give me a tip. Give me a tip, I'll get them in the room real fast. Like getting a table.
All right.
Hi, John.
Hello, Rise. How there? You got in there.
Hello.
Yeah.
Hello. Look, we have an OR crew there. On call, ready to move. Hello, Redmi. Hello, Redmi. I see you watching. Hello, how you doing? We're in the OR, looks like. I guess we're gonna take a break in the action. Hello. Take a tour on the. Hello, show us around the OR. What case do you have there? Well, I can.
Yes.
They're not manning the phone.
Maybe you can pin his screen.
Yeah, but no one's paying. Yeah, well, I can do that. Okay. Now, well, we can't. Hello there. Does anybody want to tell us what's going on? I guess nobody's manning it. Oh, wait, Dr. Wells back. Okay, hold on. Okay, Dr. Wells in. Let me get off that. What the?
Yeah, John, I'm back.
Okay, good, good. Let me unpin the video. Okay, okay. Carry on.
Yes, just a minute.
Okay.
Okay, are you with me, John?
Yes, yes, go ahead.
Now I think, I hope I don't disturb you all again. Now you see here, John, is the voice clear?
Yes.
Okay. So these kind of petroclival meningiomas with such high vascularity and such intense vascularity are extremely rare. So in 1996, as I showed you my book on complex craniovertebral junction and skull-based tumors, during that time, if you see the cover page of my book, my entire, you see, even now, the majority of surgeons all over the world, middle fossa approach are the more commonly used for petroclival meningiomas. Now, and even in my book, all the exposures, there were extensive discussion on the middle fossa approach, even including the petrosectomy. You can see in this picture, I have mobilized this. This is the seventh nerve I have mobilized. I have cut the GSPN and mobilized the seventh nerve. Carotid artery has been displaced, and this region has been exposed from the middle fossa. So this was the kind of exposure that was recommended. Essentially what I'm saying is, middle fossa was my main key. More anterior exposure, doing orbitotomy, removing the anterior clinoid process, basal pterional exposures were also, this is the picture from my book. So some pictures I will show you from my book. See, the problem is why orbitozygomatic osteotomy was recommended, because temporalis muscle is a thick muscle. And to retract this thick muscle like this on the zygomatic process or the zygomatic arch, additional 0.5 centimeter or 1 centimeter space can go. So your exposure from the middle fossa can be a little bit cumbersome. That is why zygomatic osteotomy and orbitozygomatic osteotomy were recommended at that time. And the skull base field, entire field of skull base is based on two approaches. One is orbitozygomatic osteotomy and second is petrosal approach or petrosectomy. So as we matured into this business of skull base, we had recommended, see, this is the need for zygomatic osteotomy is required because you can get this additional bone for removal and additional space for a basal exposure. We had recommended that instead of removing the zygomatic arch, you can split the temporalis muscle and you can have this basal exposure. This is what we had recommended. And for variety of tumors, particularly for softer tumors like trigeminal neurinomas, this splitting of temporalis muscle is quite an effective kind of where I don't need too much exposure. So this was the article on splitting of the temporalis muscle for basal exposure. Then we described this alternative incision, this kind of posterior incision, which exposes this root of the zygoma, roof of the condyle and external ear canal, and mastoid process for mastoidectomy. So this was an alternative incision that was described by us. And then the anterior rotation of the temporalis muscle. So temporalis does not come into the picture, and this gives me an exposure of the basal temporal structures, removal of the root of the zygoma, roof of the condyle, roof of the external canal, and we had included mastodectomy in the exposure. So this was the basal middle fossa exposure for petroclival meningiomas that I was using for quite a long period of time. Maybe for about 10 years, I was using this kind of exposure. And this is the exposure, as you can see, roof of the condyle, roof of the external ear canal, partial mastodectomy. And this was a most astounding exposure for middle fossa exposure for petroclival tumors. And this was, you see here, you can see the labyrinth is here, the facial nerve is here, the internal carotid artery is here, the trigeminal nerve is here. And to have this shot, this kind of direction, because our petroclival meningioma will be located in this territory. And to remove this, this is the region of Kawasai's triangle. So we described that you can actually mobilize the facial nerve and you can remove the cochlea. You can even mobilize the carotid artery. You can drill the labyrinth and you can have various kinds of exposure that we had described. And this is, I have already discussed with you, basal extension of temporal craniotomy. I was doing this in the year 1996. We had described this 24, 25 years ago. And I have used it, this kind of exposure for trigeminal neuroma, and I have used it for a number of cases of petroclival meningiomas, which I'm going to show you today. See, this is the petroclival meningioma. Of course, you have to come intradural because these are meningiomas are essentially intradural or subarachnoid location, elevation of the temporal lobe, identification of the location of the fifth nerve, identification of the location of the carotid artery, and identification of the various nerves and blood vessels of the region is absolutely mandatory in a three-dimensional perspective. And then we had described this tentorial dural cut. We cut the identify the fourth nerve and then cut the tentorium. So you have a petroclival area in vision from the middle fossa. So tentorial dural flap in the year 1995, I had described. So you cut the tentorium and then have a flap of tentorium and then expose the petroclival area in a more wider perspective. This flap was not described earlier. Whether it is useful or not, that you have to identify yourself. So this is the GSPN, cut the GSPN and mobilize the tympanic and labyrinthine segment of the facial nerve like this, and you drill this petrous apex and expand the Kawasai's triangle, identify the carotid artery and keep it safe or even mobilized. So this is the kind of exposure that I was doing at that time, an extended middle fossa approach, and this is the kind of exposure that we had described in the year 1995 or 1996. And as you can imagine, during that period of time, my exposures were very much basal and quite a bit of drilling of the petrous bone I was doing at that time. So this is one tumor I had removed by cutting the GSPN and mobilizing the facial nerve. And I had removed this tumor. There is some small tumor left behind here. But as I was telling you the other day, this lady was a youngish lady and she came back with a recurrence after 8 or 10 years. And she had produced 2 handsome boys in the interim at that time. And I had reoperated this person. So this was another approach from the middle fossa, and this is the post-operative scan. So what I am planning to show you is basically my concentration will be on the posterior fossa approaches to these tumors, but I will show you some tumors which have been recently operated and I found an indication of middle fossa approach. Like this tumor, I will not do any other approach but a middle fossa. Identify how much you have to expose, and this, you see this radical resection. This is the immediate post-operative scan, but you must remember when you see these scans, you have to know the relationship with the brainstem, relationship with the cranial nerve. It is not, as I have told you when I talked about philosophy of meningiomas, the trophy is not a good scan. Trophy is not a beautiful post-operative image, but trophy is the patient, how much you have been able to save the patient. This is another tumor, Clerval meningioma. You see it is quite extending towards the cavernous sinus in this cave of the Clerval junction. This is some years ago. I had done it by a middle fossa route, as you can see. But I must tell you, today, if I have to do this case, I will do retrosigmoid supracerebellar approach, which is the main thrust of my today's presentation. I will show you how that approach was done. This is another tumor. This tumor, there is no question. You have to come from the middle fossa and get this tumor, How much tumor you have to remove from the cavernous sinus will depend on the consistency of the tumor, vascularity of the tumor, relationship of the tumor with the cranial nerves, preoperative, how much the cranial nerves have been involved, what is the deficit of the patient, how much tumor you have to remove. Several factors. You see, the whole world of factors will be involved in decision making. This is another tumor, Clerval tumor going into the cavernous sinus. I thought before operation this was a trigeminal.
We may have a delay here. Hang in there. Hang in there. We're waiting for Dr. Goel to reconnect, which always happens. We've had these in the last couple of days. Still waiting. Hello, Dr. Redme in the OR, right? Can you hear me, Dr. Redmy? Perhaps not. Hello. We're just waiting for Dr. Goel to come back. Still waiting. Okay, he's back. Okay, he's back.
Yeah, John?
Okay, go ahead, carry on.
Okay. You know what? Let us see, my friend. I hope now it will remain stable, this connection.
Okay.
Okay. So now I'm ready, John. Let us work with this.
Okay.
Sometimes we have issues during operation. Sometimes we have issues during presentation. But these issues we have to handle, and we have to handle whilst remaining cool, comfortable, calm, and then go ahead as soon as our trouble is sorted out. In any case, this is a posterior clinoid meningioma. So it is attached to the clivus, it is attached to the clinoid process, attached to the tentorium, and it is having quite a bit of relationship with the cavernous sinus and with the trigeminal nerve. And you can imagine there is a calcification in the tumor. So this must be a difficult tumor. And this has been removed by the middle fossa approach. And you have to remove it beautifully. There is no question. This is another petroclival tumor, which is a very rare kind of tumor. There are two tumors in one tumor. One is transitional meningioma. One is meningothelial meningioma. This was removed by the middle fossa approach. Essentially, you have to decide when the middle fossa approach is good for you and when the posterior fossa approach is good for you. And this is another tumor which was a very difficult tumor and dangerous tumor, very firm tumor. You see the relationship with the basilar artery, internal carotid artery. This was removed quite radically several years ago, maybe 25 years ago, by an extended middle fossa approach. This is another tumor removed by a middle fossa approach several years ago. This is another tumor I had shown you the other day, which involved very extensive petrosectomy and middle fossa and posterior fossa combined to remove this tumor. These are benign tumors and they have to be aggressively handled, but aggression does not mean stupidity. It has to be philosophically and beautifully removed. This is another tumor, quite a large tumor. involving the basilar artery, some tumor has been left behind. This is another huge tumor which has been removed by a middle fossa approach. And I'm going to show you some of these tumors. Basically, my aim of my today's presentation is to show you posterior fossa approach to these tumors. See, this is another tumor, and there is some tumor left behind along the basilar artery. This is another huge tumor. There is considerable amount of tumor left behind in the posterior fossa and along the artery. This is tumor which has been removed from the middle fossa approach. This is another tumor going into the cavernous sinus. Several years ago, I had done this tumor from a middle fossa approach. I will say today I may not do it from the middle fossa approach. This is another tumor which has been removed from the middle fossa approach. This is also one tumor several years ago I had done, and I had presented this in one of my articles where I had actually done very extensive petrosectomy and mobilization of the petrosal facial nerve. And this patient is a very senior custom official, and still maybe 30 years ago, I had done this, and still she is completely active, this lady, and quite an effective approach. So what I am going to today talk to you is about retrosigmoid approach. I don't want to discuss too much about middle fossa approach. Retrosigmoid supracerebellar approach to petroclival meningiomas. This will be the basis of my today's title. And as I was talking to you the other day, conventional posterior fossa approach we had published in the year 2002. So for several years, lateral supracerebellar infratentorial approach. So this approach, supracerebellar, I think is a revolution in the field of petroclival meningioma surgery. And that is what I'm going to talk to you today about. So some of these tumors, you see, I will show you, this is a relatively straightforward tumor. May not come exactly in the definition of petroclival meningioma, more of a posterior petrous approach tumor. And of course, nobody in the world will like to do a petrosectomy of this tumor. Retrosigmoid is the approach, and all of you will agree that retrosigmoid approach will be the best approach for this tumor. Even for this tumor, which is having an attachment to the petrous bone and little bit extension here in the cave of the petroclival junction, this may not come in the definition of the petroclival meningioma, but all of you will agree that a retrosigmoid approach is the best option for this, like an acoustic tumor. Middle fossa petrosal approach may not be a good approach, or is not a good approach. Even these kind of tumors which have a lot of petrosal anostosis kind of story and a large tumor like this, I will not say that anybody in the world will like to do middle fossa approach for this. So retrosigmoid approach for these kind of little bit lateral but extending into the petroclival area may be, without any doubt, is the rational approach for these tumors. Tumors going more anteriorly. Now this is the question tumor. Whether you will like to come from front or whether you like to come from behind, this is like a regular acoustic tumor and like a regular surgery that we do by a retrosigmoid approach. Of course, this tumor is going more anteriorly towards the clivus, but going more behind towards the petrous bone. This tumor is also petroclival tumor, but the relationship of the face of the trigeminal nerve is not exactly like the definition of a petroclival meningioma, which states that the tumor is medial to the trigeminal nerve. So this is actually a medial petrous tumor, and quite a straightforward, I will say this is a very straightforward, and to an extent I don't want to use the term easy, but this may be one easy tumor to operate by a retrosigmoid operation. This is another similar kind of tumor going little bit anteriorly, and there is no doubt in it, should be in anybody's mind that retrosigmoid operation is the best operation for this case. Tumor like this, which is going into the cavernous sinus, more classical petroclival tumor, and going into the cavernous sinus. Now here, this one was operated by a middle fossa approach. Whether you would like to operate this tumor by a retrosigmoid supracerebellar approach, I will say today I will err in favor of a retrosigmoid approach. This tumor, more of a petroclival meningioma, and this post-operative scan has been operated by a retrosigmoid supracerebellar approach. And retrosigmoid approach, actually, not so much. This is a low tumor and retrosigmoid resection. So this is a higher tumor. Whether you will like to come from retrosigmoid or middle fossa, I will say this is below the tentorium. Retrosigmoid supracerebellar is a beautiful approach for these tumors. This is operated by a retrosigmoid supracerebellar approach, and this tumor has been resected. You see here preoperative and postoperative. And I will, of course, show you some videos as we go further. Imagine the relationship of the brainstem. How intense is the relationship of the brainstem with the basilar artery. And this maybe some tumor is left. This is not a contrast enhanced. This is a contrast enhanced, but this is immediate postoperative. There may be some blood here. This is another tumor which I will like to do by a retrosigmoid approach. This is a petroclival large meningioma. When the tumor becomes large, the space for surgery becomes large, and there is retrosigmoid supracerebellar approach is a beautiful approach for this tumor. And you should, there is no question now today in my mind, there is no rule for any kind of petrous bone drilling for these cases. This is another tumor which has been removed by retrosigmoid approach. The main thing is enter into the tumor by a supracerebellar route. Debulk the tumor, debulk the tumor, debulk the tumor. Get to the base of the attachment. That may be in the tentorium or in the petrous bone or in the clivus. And then remove these tumors. Just give me 1 minute, please.
Okay.
So basically the concept is reach the tumor, debulk the tumor maybe within blood. As you get space, you come and coagulate the feeders which are coming from the tentorium, from the petrous bone, from the clivus. Work within the confines of the tumor, identify the plane of dissection, and you have to save all the perforators of the basilar artery and the PCA, which is a very dramatic relationship with these tumors. This looks good, but if there is one single error during the operation, you can have a disaster at hand. You can have a situation where the person gets hemiplegia. So you have to do, there is no question that you have to do a beautiful surgery. And that surgery will, whether you want to come from the transpetrosal approach, you know, many of the neurosurgeons around the world, even today, will prefer this to remove by a transpetrosal approach. And as I mentioned to you, for several years in my own career, I was doing middle fossa approach, and we had done very extensive work on middle fossa exposures. But now I remove these tumors. With more experience I'm able to handle these tumors better. I'm able to break these tumors better. I know exactly where these tumors will be, the feeders will be coming from. I know exactly where to coagulate, and where not to coagulate. I can only tell you that if you have to coagulate a single vessel on the dome of the tumor here in this area, you have a disaster ready for you. And these patients from a very beautiful, from a cure, you can create a person hemiplegic or you can kill the person. So the death and life is in your hands. And the basis in doing benign tumor surgery is that you have to know the art of breaking the tumor. This is another tumor which is more laterally located, and this is post-operative scan from the retrosigmoid supracerebellar approach. Break the tumor, break the tumor. I will say this tumor is relatively straightforward tumor to operate. Question is, you have to save the 7th, 8th nerve complex, which is here. The 5th nerve, which will be in the entire surgery, it will be under your vision. The posterior cerebral artery will be under your threat, and that is the major threat to these tumors. This is another Pedro tumor. This is not an acoustic tumor. This is located quite medially, as you can imagine. And you have this post-operative image, which is a beautiful image. And I have to only tell you that these tumors can be fantastic tumors to operate, difficult to operate. And today, in my personal era of neurosurgery, I do these tumors by supracerebellar approach. And I have to tell you that this term supracerebellar is a revolution for petroclival meningiomas. Now you see this tumor, this has quite a bit of attachment here in the region of the petrous apex. And I am not exactly sure what approach I did for this case, but this has been removed. And I'm not sure whether I did it from the middle fossa or from the posterior fossa, but this tumor has been removed. From the posterior fossa may be a beautiful option, but I'm not sure whether this particular tumor was done, but this is the post-operative scan showing beautiful resection. This tumor, you see, this tumor has been removed by a posterior fossa supracerebellar approach, and the part of the tumor extending into the region of cavernous sinus has also been removed. It is possible to remove this tumor. Many a times you may leave some tumor behind here in the cavernous sinus because the exposure may not be good enough. It may not be a bad idea to leave some tumor behind and to remove this tumor, because this tumor, you can reach the tumor in 5 minutes, you can reach the tumor. Do a craniotomy, retract the cerebellum inferiorly, cut the petrosal vein early in the operation, identify the 5th nerve, identify the posterior cerebral artery early in the operation, enter into the confines of the tumor, learn the art of breaking the tumor, learn the art of demolishing the tumor, identify the feeding vessel, identify the feeding vessel in the clivus, in the petrous apex. Most important is the 6th nerve in this region that you have to avoid. You cannot remove this tumor and kill the 6th nerve. Maybe it is I'm not saying I can preserve the 6th nerve in all my cases, but 6th nerve is the bottom of the surgery. You cannot leave the bottom. And you have to, you have to know how to coagulate. If you keep on coagulating in this area, you may kill the 6th nerve quite frequently. You have to know how to avoid coagulation in this area. You have to, of course, I'm not saying you cannot remove without coagulation, but you have to learn to avoid coagulation in this critical area of the 6th nerve. This is another tumor. You see it is going above the tentorium. It is a classical petroclival meningioma. You see the relationship of the brainstem, and this is some tumor probably has been left behind in the region of the cavernous sinus, but otherwise this tumor has been removed. Even the part of the tumor going above the tentorium can be quite safely removed. Make an incision in the tentorium, get the whole piece down, and that is the trick that you have to learn. The question that I'm trying to answer is that supracerebellar approach is a beautiful approach even for the tumors which are going above the tentorium. This is another tumor going above the tentorium, and this has been removed by a supracerebellar approach. you have to, of course, I'm not trying to say that these are all straightforward and simple tumors. They have their own problems. They have the problem of vascularity. They have the problem of consistency. They have the problem of relationship to the blood vessels. And I will certainly show you some of my more complex cases. This is another tumor mainly in the posterior fossa, having a relationship with the basilar artery, and this is the post-operative scan showing a beautiful resection. In this case, you will notice that there is another tumor here. And when there are multiple meningiomas in the body, the surgery becomes relatively easier. Like when there are multiple aneurysms, the aneurysm surgery is much more easier when you operate. Similarly, when there are multiple meningioma, this tumor, I am not sure how much time I took, but I must say this must be very quick operation. The other day, I told you that no neurosurgery should be more than 1 hour, and I retained that statement even for petroclival meningioma. I retained that statement for your information that petroclival meningioma does not mean 20-hour surgery or 15-hour surgery. Learn, enter into the tumor, break into the tumor, break into the tumor, demolish the tumor, preserve the planes, preserve the artery. One mistake you make, once perforator injury you make, you kill the person. This is another tumor you can see has been removed completely and beautifully. There is some residue here. For some reason, I must have left this residue because of the relationship, or maybe I could not expose this, but there is a small residue I can see, but this tumor has been resected beautifully, and you have the power in your hands. Have the experience, have the anatomy, have the how to retract the brain to expose the tumor, how to handle the cranial nerves, how to preserve the perforators, how to avoid damage to the perforator, and more importantly and more crucially, how to avoid the damage to the 6th cranial nerve. I have given you one trick that avoid the extensive coagulation in the region of clivus, break the tumor, break into the tumor, and learn the art of breaking the tumor. This is another tumor which is going into the cavernous sinus in the region of this cave of the petroclival region. So some tumor was left behind. I do not know what was the reason. Maybe I could not expose this part during the operation. Was done several years ago, and this is the post-operative scan showing quite a good resection. And this, I will say, you remove the tumor as radically and as safely as possible. The merit is to preserve the patient's function. That is the aim of our treatment, and our life will depend on how much we save, rather than our trophy is not the post-operative beautiful scans that I'm showing you, but our trophy in our life of neurosurgery is how much we have preserved the patient. You see this tumor I have removed from the retrosigmoid supracerebellar approach. You see the vascularity is coming from here. Quite an extensively vascular tumor. You can imagine vascular tumors are soft tumor. On T2 weighted image, you can see T2 very bright tumor. So this is a soft tumor. So break the tumor amidst blood vessels, amidst bleeding. Now you will ask me how you operate within a bleeding territory. If you cannot operate within a bleeding territory, you will not be able to remove this tumor. And also I have to tell you, prolonged retraction of the brain, prolonged retraction of the cerebellum, doing this operation for 10 hours and 15 hours certainly will not be a very good kind of a surgical experience. And also, you see these vessels have to be handled when this tumor has been removed. You cannot handle these vessels unless you have removed a large part of this tumor. And then when you have exposed this area, you coagulate. So that learning how to first remove this tumor which will bleed. You cannot go to the base of the tumor with this tumor hanging in front of your nose. So you have to first break this tumor and then come here. So that is the kind of tumor resection. This is the post-operative image of this tumor. This is another tumor. You see the vascularity is coming from the base of the posterior wall of the cavernous sinus. You see the cavernous sinus extension, posterior wall of the cavernous sinus. This tumor also has been removed from a retrosigmoid supracerebellar approach. You see another beautiful tumor which is going in the cavernous sinus, having quite ragged edges, having quite an intense relationship to the nerves and blood vessels of the posterior fossa. Some tumor in the cavernous sinus has been left behind. Retrosigmoid supracerebellar approach to this tumor. So this is another tumor. You see here, beautiful. This tumor is encasing the vertebral artery and basilar artery. As you can see, the whole basilar artery is encased by the tumor. And this is post-operative scan. And this is the video I want to show you of this. This is the terminal part of this operation where the entire tumor has been removed. This is the basilar artery. This is the fifth nerve. And these are the sixth nerve and other things here. And this is the vision that I'm seeing from the posterior fossa. This is the tentorium. You see, this is the fifth nerve that you can see, and the other anatomy that you are seeing here. This is another tumor, and I am going to show you a case where I had a disaster and where I had damaged this during the operation. But fortunately, this PCA, and I want to show you almost an unedited tape of this case. Here you will see this is the dural incision. This is the right side. This is the transverse sinus. Here is the sigmoid sinus. My incision is going right up till the transverse sinus, and I take two dural flaps. I first go in the CP angle and open the cisterna magna to relax the, you see now the brain is relaxed. Now it will not be very much edited, my further part of this operation. The bridging veins have to be coagulated to be able to retract the cerebellum. Now here, as I mentioned to you, I had a significant problem with the posterior cerebral artery, and I had considerable difficulty during the operation to control that bleeding. So I'm trying to show you a little bit of a case where I had a big problem. So this petrosal vein has to be coagulated early in your operation, because unless you coagulate this, you will not be able to retract the cerebellum. So you are going supracerebellar. You see supracerebellar. I'm cutting the petrosal vein. I know the video is not such a clean video. This is also very old presentation of mine. So I have cut the, and this is the fifth cranial nerve which is coming into the picture. Entire tumor is medial to the fifth nerve. You see it is attached to the tentorium, and I am trying to dissect the tumor from the tentorium. First I will coagulate. Here is the fifth nerve, and I am trying to remove this tumor. You will see my problem that I faced during the operation. What I'm trying to do is, first I'm trying to disconnect the tumor because it is a firm tumor. This is not a soft tumor that you are seeing here. And your image is also, the field is quite narrow. Now I'm having the tumor and I am breaking into the tumor. And it will, you know, here, as I mentioned to you, I am having a problem with the posterior cerebral artery. And that was not a small problem. And as I mentioned to you, in our life of neurosurgery, here I am setting the fifth nerve of the tumor. With my suction, I'm dissecting the fifth nerve, which can be quite difficult on occasion. And now I am medial to the fifth nerve, and I am breaking the tumor. And I'm trying to identify the tumor, the relationship of the tumor with the sixth nerve. As I have told you, this is not too much edited. This is completely, now you see by the time I was dissecting, I have got into a blood vessel. Now this is what I'm trying to show you, that my problem is now when you see a bleeding like this, I'm seeing the artery here. Now if you coagulate the artery, then it will be the end of the story. Now you have to, now I'm trying to remove the tumor and trying to dissect the tumor artery from the dome of the tumor and avoiding to coagulate at this time. Maybe I'm not sure what I did later. Maybe I had to coagulate. But what I'm doing is you see, this is the artery which I'm separating off the dome of the tumor. I knew, you see the artery you can see here. It is traversing on the dome of the tumor. Whilst there is bleeding going on, instead of trying to handle that bleeding, what I'm trying to do is I'm trying to more debulk and break into the tumor to find space to deal with that artery. Whether I need to take a suture in that artery, whether I need to coagulate that artery, I'm trying to identify, but I can identify only after this tumor bulk is removed. See, I cannot do anything to the artery unless this tumor is out of my picture. So what I'm trying to do is I'm trying to remove the tumor, and this is the artery. You see, here is the artery which is quite severely encased by the tumor, and I will be separating the artery and dissecting the tumor. And this is and my exposure is not terribly huge. You see, some of these tumors can be, you can kill the person. You see, now I have separated that artery. You see, from the nubbin I have separated, and then I will be removing that tumor. You see, I have separated the artery from the tumor nubbin. It will bleeding. But what I'm doing is, first I'm getting rid of that artery tumor dome, and then I will remove the tumor. Removal of tumor is okay, but you have to preserve the cranial nerves also. Now I know exactly where is the tumor attachment. In the meantime, whilst I was having the bleeding, I have even dissected the tumor, and then I will see how I have to remove this tumor. It is still bleeding, as you can see, but the question is, I have to, you see, I have removed the tumor from the brainstem, and I have got into the tentorium here, and I will get the feeding vessels in the tentorium. You see here, I'm coagulating the tentorial feeding vessels quite late in the operation. Up till now, there may not have been any single coagulation in this operation. See, when I say these things, you find that it is little unusual. You see, on the other hand, coagulation within the confines of the tumor all the time may not be such a great idea. Now I will try to find out where that posterior cerebral artery is and where it was bleeding. And you see, sometimes, I'm not sure, in this case, it has stopped spontaneously. Small hole in the artery will stop spontaneously. If there is you see, there is a basal artery now here in my entire view, and here is the posterior cerebral artery in my entire view. Imagine if I had coagulated early in the operation, that would have been the end of the artery. Now I am having a situation where the bleeding has stopped spontaneously from that hole. So that was the tumor. This was the artery which I ultimately handled and removed. This is another case. You see, this was the tumor, and this is the basilar artery, and this is the whole tumor has been removed. There is a small tumor which has been left behind, and I want to quickly show you the terminal part of this operation from the supracerebellar avenue. You see, supracerebellar. And this is the fifth nerve. At the quite an end of the operation, if my bipolar has come, and you see the vision which I am having from the supracerebellar, superior, I can see the pituitary stalk, I can see the hypothalamus, all the perforators are intact, and this tumor has been removed. This is another tumor. You see the arteries are encased by the tumor quite badly, and this is the view that you are getting after the tumor resection. And let me see if I can show you. I'm not sure if I'm showing you the surgery here, but at the end of the surgery, I'm showing you the fifth cranial nerve, the entire basilar artery, the vertebral artery, the sixth cranial nerve is here. And you see here, this is the 7th, 8th nerve complex. This is the lower cranial nerve complex here. From the supracerebellar avenue, you are seeing the entire posterior fossa, entire field you can see. You see, it is difficult for me to show you the entire videos of these things, but you can just imagine how the surgery has been done. This is another tumor which has been removed quite completely and radically by a posterior fossa operation. Supracerebellar approach. I will not do a middle fossa approach today. I have shown you how I was doing middle fossa approach earlier in my lifetime, but this small tumor here, I will say I will like to remove this tumor from a posterior fossa approach, and most important is learn the art of breaking the tumor. Learn the art of not coagulating and removing the tumor. Learn the art of demolishing the tumor earlier in the operation before going to the base to coagulate. These are very important tricks for all neurosurgeons to learn. And we learn this during our lifetime. And if earlier we learn, better it is. You see this tumor, not much in the middle fossa, pictoclival classical tumor. It has been removed beautifully by a retrosigmoid operation. This tumor was quite a vascular tumor. Basal attachment. If you have a small tumor, if you have a basal attachment, definitely I'll first go to the basal attachment, coagulate basal attachment. But in largest tumor, I will remove the tumor, debulk the tumor, then go to the base of the tumor to resect this tumor completely, radically. That is the aim of surgery. This is another tumor. You see, nowadays, for last several years of my life, I am presenting more on craniovertebral junction, on Chiari malformation, on spine, and you be prepared to see from me a spinal revolution, which I'm going to present in you. You just cannot miss that presentation of mine, a revolution in spine surgery. And I want all the people who are listening to me today, they must see that presentation of mine, a revolution in spine surgery, which I will show you very soon. You please do not miss that presentation. So these presentation, I was giving on pictoclival meningiomas few years ago, and this is from this presentation which I'm showing you has been presented at least 7 or 8 years ago. These whatever cases I'm showing you are very old cases of mine. I have not collected recently my cases, but I will show you in subsequent lecture. This is another tumor. You see some tumor in the middle fossa. This is more recent case. You can see the quality of MRI is better, and some tumor is remaining in the cavernous sinus. This tumor has been removed, and beautifully, I just love to live this life of neurosurgery, and it gives me such a nice kick but also you must remember, you get a good kick of the surgery, and you can be kicked after the surgery if you take any single vessel in this territory and single nerve in this territory. You see some tumor has been left behind near the 6th nerve. Maybe there was some difficulty during dissection of the 6th nerve. Why I have left this tumor, I am not sure, but maybe my reach from posterior fossa was not complete, and I missed some of this tumor, but this tumor could have been removed, I have a feeling. Tumors going more down in the clivus. There is no other approach. Middle fossa approach is not the answer at all. You have to learn how to retract the brain, how to learn how to do the dissection between the cranial nerves. This tumor also I have removed at least 25 years ago, this tumor, clival tumor, from a retrosigmoid operation. I'm not sure whether I included the posterior middle fossa approach also in this case. I can see some pictosectomy here. Maybe I have done some pictosectomy to remove this tumor, but today, without any doubt, I will remove this tumor by a pure retrosigmoid supracerebellar approach. This tumor, I think some pictosectomy has been done. This is another tumor which is going low down in the clivus, and this is also relatively new. By the quality of scan, I can tell you this has been recently done case by a retrosigmoid operation. This is another tumor which has been beautifully removed. So this is a classical pictoclival meningioma. So what I'm trying to show you is many of these pictoclival meningiomas, like this clival, midline clival tumors. I can tell you this tumor could have been removed in 20 minutes or half an hour or 45 minutes, not more than that. Demolish the tumor, demolish, expose the tumor, learn the art to remove this tumor from small exposure, enter into the confines of the tumor, demolish the tumor, debulk the tumor within a bloody field, identify the feeding territory after you have removed the tumor, and then go to the base and coagulate, and you can remove this tumor quite beautifully and quickly. So this is the tumor. I do not know what I'm showing you, but just let us see what has been shown. It has the end of the surgery is being shown here. This is the left side. When my coagulation has come, it means it is the end of the surgery. And you see how much this is supracerebral exposure right up to the foramen magnum. You can see these are the cranial nerve. This is the larger one is the fifth nerve. Then you can see how I'm working above the fifth nerve, below the fifth nerve, and this tumor, this is some blood in this area. You can see the entire tumor has been removed. This is another tumor which I'm showing you. I'm not sure what exactly I'm showing you, but just let us see. Wait, I think I am a little bit, just a minute. I will just pull it a little bit towards this side. You see here, what I'm trying to show you is that you can have such a big, wide exposure by the supracerebellar avenue, and you have to learn how to tease the tumor of small blood vessels, of vessels around in that area. And you see my exposure and my field of surgical field. And I'm exposing the entire clivus. You see the basilar arteries here. This is the right side tumor, basilar artery, complete basilar artery. And these are the posterior cerebral artery in the picture. I'm just trying to remove some blood to show you the picture. And you see this tumor was operated in one of my workshops, which I conduct on a regular basis in my hospital. And this tumor has been removed quite radically and quite quickly. And this is a presentation in my workshop. And some of you who have attended, I know some of you in the panel have attended this workshop where I have shown this case. How to demolish the tumor, how to operate within a bloody territory, and how you see here, this is actually, as you can imagine, this is the end of the surgery. And I'm just trying to show you the anatomy after the surgery. The basilar artery is again seen beautifully, and the vertebral artery is seen. And let us see what else we are going to see in this operation. Neurosurgery is a subject of a lifetime. This is the most wonderful subject. You can give new life to the person if you do a good operation. On the other hand, if you create any mistake during the operation, you can have a disaster which is meant for you for a few days, but for the lifetime for the patient. You see some tumor on the pole of the dome of the tumor, which I am going to remove now. Probably, I'm not sure what is shown here and what is done remaining, which has to be removed. I'm sure I will remove this tumor now. But more important, I'm trying to identify, removing the bulk of the tumor, what is the relationship of the remaining tumor with the arachnoid, with the blood vessels, and with the cranial nerve. in the petrous apex. I'm trying to go now here. Here I have to identify and save the sixth nerve. Coagulation has to be very, very gentle and precise. And I can see the sixth nerve coming in the picture in this after I retract the cerebellum. Let us see if I will be showing you the sixth nerve or not. I'm not sure, but probably you will see. See, this is the fifth nerve, which I am elevating here. You see the fifth nerve? The complete fifth nerve is being elevated. And here is some clot which is removed. And the fifth nerve is in its entirety. And here it is medial to the fifth nerve. Petroclival meningiomas are tumor medial to the fifth nerve. And you can see the, now this is actually, the tumor has been removed. The edited version, that part of the tumor has been removed now. And you can see the part above the fifth nerve, and there's some darkness is there. Let us see if there is some light in that dark tunnel. Actually, you can see the contralateral nerve here. So I have stopped the video. It means that the surgery is terminated, and you can see the entire area, beautifully done tumors resection. And this was actually the previous one. Wait, let me. So there is, the tumor was resected. So this is another tumor which has the sixth nerve is involved by the tumor. So when it is involved by the tumor, does not give you a liberty to take a chance with that. So what I have left some tumor behind on the sixth nerve, despite the fact that this patient has come with the sixth nerve deficit. You see, there is a sixth nerve deficit. I have left some tumor behind on the sixth nerve, along the course of the sixth nerve, in an attempt to save the sixth nerve. I know that this sixth nerve had not improved in this patient. This is another tumor. There is some tumor left behind in this territory and in this region of the sixth, on the cavernous sinus. This is another beautiful tumor, which was a technical, I will say, a complete beauty for me in my lifetime. And I had left some tumor behind along the basilar artery. You can see is encased by the tumor. Some tumor is left behind here. Some tumor is left behind in the carotid artery. You see the entire tumor is displacing the brainstem quite dramatically. A considerable amount of tumor has been left behind, but this patient had come out completely beautifully. This is another tumor having a relationship with the basilar artery. I've left behind considerable amount of tumor. So as I was mentioning to you, your trophy is not the extent of resection. This does not give me any kind of bad marks in my operation. This tumor, only a smallish amount of tumor has been left behind. If I have left behind some tumor here, I was telling you the other day, extent of resection is not my aim of surgery. Preservation of all the blood vessels and perforator is the aim of my surgery, particularly for these kind of tumors, which are complex neurosurgical challenge. As you can imagine, these are not ordinary neurosurgery. This is a complex neurosurgery. And here I have left a little bit more tumor behind, probably because there must have been significant difficulty in dissection. Unless that difficulty is significant, I will not leave this tumor behind. The aim of surgery in all my operations for last 30 or 35 years of my life is radical surgery. For any kind of tumor, my aim is radical surgery, but my aim is preservation of the patient, preservation of the blood vessels, preservation of the cranial nerves. I will leave some tumor behind if it actually comes to. This is another tumor, which is a huge tumor, and I have a follow-up of several years on this person. Young man, he always comes and gives a very nice hug to me. In our Indian scenario, he comes and touches my feet. I don't want to become a heroic at that time, but I must tell you, he has got some great regard for me to remove this solid tumor, which was already operated by somebody else earlier. From the middle fossa approach, a large amount of tumor has been left behind in the Clerval region of tentorium, and this patient is quite all right for at least 7 or 8 years after surgery. Tumor which are difficult to remove are inherently aggressive in nature. So sometimes when my dissection from the cranial nerve is difficult, when my dissection from blood vessel is difficult, I now come to the conclusion that these tumors are inherently aggressive. When I get a clear plane of dissection from the tumor, when the arachnoid plane is good, those tumors are inherently less aggressive. Recurrence in these cases is related to more to aggressive nature of the tumor rather than incomplete resection. Easier the tumor, well-defined, good arachnoid plane of dissection, more benign is the nature of the tumor. This is what my learning is. So my conclusion to you, young friends and senior friends, conclusion is resect the meningioma radical. Radicality of resection is important. Unless we are made up of radical material, made up of aggressive material, made up of confident material, made up of hyper-confident material, we cannot remove these tumors. But radicality is not the aim of operation. Patient should improve in the symptoms. If there is symptomatic improvement, recurrence, then only there is a need to operate. Role of radiotherapy for benign meningioma is controversial and not proven. Avoid it. As long as you think we can remove the tumor safely, as long as you can think we can remove the tumor radically, use your knife. Do not use any gamma knife or any other kind of radiation treatment. So thank you, my dear friends.
Okay, thank you very much, Dr. Atul. Okay, I'll turn it right over to Manas.
Can you remove the screen now, John?
Yeah, sure. Okay, Manas, you can take over, okay?
Okay.
Okay.
Thank you, Professor Dr. Bennett, for asking me to moderate. And Dr. Atul Goyal has explained it so well that I'm sure there will not be many questions. But then we have a question from Dr. Suchanda from Hyderabad. She has asked, what's the position for retrosigmoid supracerebellar approach in these cases?
Yes.
I think you showed a
Suchanda,
video on that. Yeah.
Suchanda, you have asked me a question, which is very fantastic question. And I actually, I should have mentioned in my presentation that this supracerebellar approach can be done in lateral park bench position also. It can be done in lateral position also. Park bench may be a better option, but I do them in sitting position. And I find sitting position a very beautiful approach for these tumors. And I do, to answer your question, I do in sitting position. Now, sitting position you can do if you can do this operation in relatively quick time. If you can do it in 1 hour or 2 hours, maybe you can do it. But if you are a little bit slow surgeon, like many of us are slow surgeons, and if we take 4 hours, 5 hours, 6 hours, 10 hours, then you have to use park bench position, and then you have to appropriately position your head to operate in a lateral position, in a park bench position. But I do sitting position, which is good for me because many of these tumors, I like to do them very quickly. Okay, Suchanda?
Yes, sir. Thank you, sir. Yeah.
Thank you.
So earlier you used to do like transpictures for these cases, or you never did? All the time you did retrosigmoid supracerebellar?
No, Manas, I have started doing, as I mentioned, I don't know whether you were present earlier in my presentation.
I was there. You said you changed over. I wanted to ask, why did you change over?
I changed over because, as I became more mature in handling the tumor, as I became more confident in doing acoustic tumors. During that time, I was doing, as you can imagine, we grow up in our neurosurgery in doing acoustic tumors. As we did more and more acoustic tumors, as we became, you see, as we did some petroclival tumors by retrosigmoid approach, by supracerebellar. But I can tell you, Manas, and other people in the panel, that supracerebellar approach is a revolution in the field of petroclival tumor surgery. I used to do many of these tumors for 10 hours, 15 hours, whole day I was dissecting and drilling the facial nerve, and I described that facial nerve mobilization technique, total petrosectomy also I used to do, total, complete, and I showed you my book which has a total petrosectomy. I used to do all kind of petrosal drilling continuously for hours and hours using diamond drill, small burr, big burr. Now you will be surprised that petrosal approach does not come in my field. For last 20 years, I have not done a single petrosal approach. I have not done a single case with orbitozygomatic osteotomy, which I used to do on a regular basis, as you know. Probably you have seen in my department during your earlier days. I don't do them at all I don't do. So this is how I have actually matured into my own world of skull base.
So it is like with experience, one probably can do with a simpler approaches than doing a complex approach.
Yes, that is what is the message I want to give to the younger people, that you learn how to remove the tumor, learn how to break the tumor. Then you can do it with simpler approaches, smaller approaches, and the results also will be good. You know, as you are growing in this field of tumor work, and particularly in petroclival tumors, you know you have damaged the sixth nerve, the patient will never excuse you in his lifetime. They develop diplopia, they will never be happy no matter how much your post-operative scan is looking beautiful. So it is the patient that matters. And if you know the art of handling the tumor, breaking the tumor, you can remove them in smaller exposures with better post-operative outcome. And supracerebellar approach, selected middle fossa approach for tumors which are going in the middle fossa.
Thank you, sir. There's one more question from Dr. Anna. She has asked if somebody has operated a meningioma and partially and given radiotherapy, how do you manage? Is reoperation during reoperation, is the dissection from cranial nerves and brainstem more difficult?
Yeah. As you know that once you enter into radiation, the repeat operation becomes quite difficult. See, radiation has a role. I'm not saying radiation does not have a role. Please don't misunderstand me. Radiation has a big role in meningiomas. And radiation has a game-changing role. And you can actually cure the tumors which are going here and there. You see the aggression of the tumor, understand these meningiomas, and radiation will certainly come into the role. But if you think you can do it with your surgery and remove the tumor by your operation, that is the best treatment. But you have to be very confident in removing. You can be creating a very big blunder in doing. Now, as far as tumors which have been radiotherapy, tumors which have been removed earlier, it becomes more difficult. But even in that situation, you have to identify, yes, it is possible to remove. No, it is not possible to remove. From your experience, you have to identify if they are soft tumors, if they are firm tumors, if they are vascular tumors, whether they are removable tumors or not. That you have to identify with your experience.
Dr. Imam has asked that, could you please explain how you preserve the arachnoid plane?
That is also one very essential in meningioma surgery or in any neurosurgery. You be aggressive with the tumor, but respect the membranes. Absolute respect to the dura and absolute respect to the arachnoid. and complete respect to the pyre. The vessels are in the subarachnoid plane, and you have to dissect them in a beautiful, that two-hand dissection has to be there, two hand. You cannot say I will use one hand and one hand will be bipolar. You have to use two-hand dissection. And how you have to dissect, you have to learn as you grow into the field of neurosurgery. Manas?
Yeah, there's one more question by Dr. Andy. He has asked, have you ever experienced problems with small posterior fossa where it's very hard to let out CSF even when you use a lumbar drain? So how do you have cerebellar relaxation?
Tight posterior, you mean tight posterior fossa?
Tight posterior fossa.
Yes.
Yeah.
Yes, you have a tight posterior fossa, then you have to find your way. You can have a tight brain, the tumor can be big. You have a large acoustic, you can have a tight brain. You have to know how to get the CSF from the cisterna magna. You have to have have a handle of the tumor. I will say, even if my acoustic tumor, for that matter, sometimes the brain can be tight. I will never advise removal of the cerebellum or resection of the cerebellum. I will never advise. I have never done in my lifetime. So you have to find space to get the CSF from the cisterna magna or from whatever, and get a small space into the tumor and debulk the tumor in a smaller space. As you debulk, you see, if you cannot debulk the tumor in a smaller space, and if you need to coagulate at each step of your operation, you cannot do many of these acoustic tumors by a retrosigmoid operation. The brain can be tight. So you have to learn how to handle the tight brain and learn how to get into your CSF spaces. I would say for acoustic tumor, no matter how big it is, you get into the cisterna magna early in the operation, and you will get space for further dissection.
Yeah, there's a question by Dr. Rupesh. He is inquired whether do you prefer embolization before operating on petroclival meningioma?
I am very happy to see Rupesh. As you know, Manas, Rupesh is our favorite young man. No longer a young man, no longer Manas is a young man. They are all experienced and wonderful surgeons and very skilled surgeons. And Rupesh, another favorite of mine, is a very skilled neurosurgeon. And he has asked me this question about embolization. Rupesh, my answer is I do not use embolization. I do not recommend embolization for any meningioma, for that matter. I was saying the other day, I do not recommend embolization for nasopharyngeal angiofibromas, where I used to do embolization earlier, but I have my patient has lost vision following embolization in not one, but in 3 cases. So I've completely abandoned embolization for nasopharyngeal angiofibromas. I still like, for glomus tumors, I like embolization, still I like. But I'm not sure whether I will continue to like embolization. For meningiomas, for sure, I do not like preoperative embolization. Rupesh.
Yeah, Dr. Salek has inquired if you ever combine the retrosigmoid with the pre-sigmoid approach.
As I mentioned to you, pre-sigmoid was in my range of my surgery for a long time, for several years, and I used to do pre-sigmoid from a middle fossa approach. What I used to do is, I used to do mastoidectomy. I used to enter into mastoid antrum early in the operation from a middle fossa approach. And my direction of approach was from the middle fossa, like this, down. And then I used to get into the pre-sigmoid territory, and sometimes I used to, and that superior petrosal sinus was relatively easier to cut from a middle fossa. But now for a long time, I do not do it. And if I have to do, if my exposure is incomplete for a middle fossa component of the tumor, I may like to do a second stage middle fossa exposure, but I do not combine because my approach is sitting position. And in sitting position, of course, you cannot do mastoidectomy in sitting position. But if I have a complex case, then I may do a more radical petrosal exposure, which I used to do on a regular basis earlier in my, for 15, 20 years, I used to do. And that paper which I showed you, extended middle fossa approach, was quite a well-cited paper in the literature. Okay,
Yeah,
Manas?
Yeah, there are lots of questions. 10 more questions. Dr. Imam has asked, could you explain your philosophy of means the tips of breaking the tumor? How do you don't use ultrasonic aspirator, you use just suction. No, doctor, this is Dr. Avinash, not Imam.
No,
Dr. Imam
no
has
ultrasound, no ultrasonic aspirate.
Dr. Avinash has asked this, how do you break the tumor?
Now, Avinash, if you are Mr. Avinash, then you have to come here to see this in my department. For you, if it was somebody else from Sudan or somebody, then I would have answered it more elaborately. For you, I am answering, come here, spend some days with me, and then I will discuss with you when I show you how to break the tumor. Basically, I break the tumor in various ways, and it is a little bit difficult to explain to you. Okay, Manas?
Dr. Imam has asked, please explain your philosophy behind the doing coagulation at the end of surgery.
This is also a little bit difficult to explain. You see, what happens is, if the tumor is right in front of your nose and right in the field, then it is, you see, unless it is an anterior clinoid meningioma. Anterior clinoid meningiomas are different. Supracellular meningiomas are different. In supracellular meningiomas, you have to come first and break the tumor, and then early in the operation, you can do coagulation of the tuberculum celli and basal planum sphenoidale if necessary. But petroclival meningiomas, what happens is the vascularity comes from the clivus and from the tentorium and from the petrous, which are in front of the tumor. So unless you remove that front part of the tumor, you will not reach that basal attachment. In that respect, to remove the petrosal bone, if you drill the petrosal, that petrosal bone drilling and all those things which I used to do earlier, in that respect, you will come in the vascularity of the tumor early in the operation. You can handle the vascularity from a petrosal approach, from a transpetrosal approach. You can come to the vascularity earlier in the operation. But nowadays, I don't think that to control the vascularity earlier in the operation is really a necessary surgical trick for me.
Dr. Raghuram has asked if there is a high clivus tumor, small tumor, with high pneumatized sphenoid sinus, can we do a transsphenoidal approach?
For petroclival meningioma, I will not, I will certainly, you see, I don't, you know, you may be having some kind of special tumor in your mind. You might be having a tumor which must be a little bit different kind of tumor. If I see that scan, I will be able to better tell you whether I will do it or not. But in general, under no circumstance, I will remove any tumor, meningioma tumor. I will not remove any tuberculum celli meningioma, any petroclival meningioma, any clivus meningioma from nose. I know there are some people who will like to do, you see, there are two things. It is whether it is possible to do or whether it is better to do. It is possible to do. I used to do transoral meningioma removal in the clival meningioma. I have published a paper on this, transoral removal of clival meningioma. 25, 30 years ago, I used to do these kind of, you know, heroic kind of, I can do. But today, I will not recommend. Your case must be a little bit different kind of tumor. I would like to see the scan, but in general, my philosophy is absolutely clear. No endoscope for tuberculum celli meningioma for me. No endoscope for any meningioma which is going inside the skull for me, period.
Thank you, sir. Dr. Uday Bhaumik has asked, in retrosigmoid supracerebellar approach, do you encounter petroclinical fold? And do you open Dorillo's canal? And how do you tackle cavernous sinus bleeding? 3 questions.
Yes. See, if the tumor is going in the cavernous sinus, then you cannot completely remove from the posterior aspect. Means you can remove, but your exposure can become a little bit compromised. In that situation, you have to drill the petrous apex medial to the internal artery meatus, under medial and under the 5th cranial nerve. And then you have to remove the tentorium and go into the tentorial dural folds and go into the cavernous sinus. Sometimes what happens is the tumor, the bulk of the tumor has eroded the petrous apex. For example, trigeminal neurinomas. If you are doing a trigeminal neurinoma from behind, you can easily extend your exposure right in the middle fossa and remove the part in the middle fossa, because the tentorial, that edge is eroded, the petrous apex is eroded. But of course, in the cases of meningioma, there will be vascularity coming from that field, that area, and the bone may not be eroded. On the other hand, there may be anostosis, the bone may be thickened there. So you have to drill that area if it is necessary. If you realize, many of the cases I showed, there was some part of the tumor in the cavernous sinus was left behind because my exposure probably was not so great in those cases. So, and the tentorial dural folds are 3 types. One is fold from the anterior clinoid process to the posterior clinoid process. One is from the posterior clinoid process to the, one is interclinoid dural fold, petroclinoid dural fold. So there are 3 folds, and there is a triangle in the roof of the cavernous sinus from where the 3rd nerve goes. It is sometimes, or quite, it is a little bit challenging to expose that triangle from the posterior fossa. For epidermoids, when I will show you epidermoid tumors. In those tumors, you can easily expose the 3rd nerve entry and all those things in epidermoid, which are softer tumors. But in meningiomas, you have considerable difficulty to expose. It may be better to leave that part of tumor behind, because the 3rd nerve can be compromised in that situation. And then you can come, if necessary, from the middle fossa or from the perineal base or something like that. Manas.
Yeah, there's one more. Thank you, sir. There's one more last question by Dr. Vikrant. It's a similar question. He has asked whether do you consider cutting the tentorium medial to the 5th nerve to deliver tumor extending into the middle cranial fossa, which I've already answered now.
Yes, I showed you my tentorial dural flap, which I described for the middle fossa approaches. And I will show you the tentorial dural flap, how to cut, when I show you my subsequent presentation. More easily it can be cut in the cases of epidermoid tumors. So I had described a beautiful approach which I will show you for epidermoid tumors, where the tentorium can be cut rather easily, as you can imagine, Manas, and then you can go in the middle fossa rather easily in those cases, and I will show you. So you have to cut the tentorium if the tumor is going up. If there is some tumor which you are not able to deliver the posterior fossa, you are not able to deliver the superior part of the tumor. In those cases, you might have to cut the tentorium.
Dr. Laziz has asked, what is your experience in removing the supratentorial part from the retrosigmoid suprameatal approach?
No, it can be removed. A large part you can deliver. You see, you gradually remove, debulk the tumor, the supratentorial part will come into your picture. And you take a tentorial incision and work in that area. It is of course, every step of petroclival tumor surgery is difficult. Every step is not for, not for children. These operation, as you know, Manas, you have also developed over the years. You have developed confidence. You have developed tricks to cut the tentorium. You have developed tricks to break the tumor. You have developed your art in extending your exposure, and you have to be quite versatile in removing these tumors. You cannot, these are not for, these are not child's game to come, remove and cut tentorium and deliver the part of going up and all. But you can develop your skills and develop your strategy and develop the art of removing these tumors.
Yeah, thank you, Professor Goel, because Dr. Bennett is warning us that he has another webcast to do in short time.
Okay. Okay.
And
Thank you very much, Manas.
thank
And
you, sir.
it is a pleasure to see you and pleasure to see the other panelists. And my best wishes to you, and enjoy the beauty of Pedro tumor surgery. Thank you, John. Thank you, John.
Let me
Thank
just
you,
show
sir.
you, let me just show you, Dr. Goel, what we have coming up here. And I don't know how busy you are, but we have a conference with your friend, Dr. Sabea in Jordan. He's going to present on pineal gland tumors in 45 minutes. And a spine surgeon from England is going to present Introduction to Endoscopic Pituitary Surgery in about 4 hours. Okay, so
Okay.
if we have nothing to do, stop by, and thank you, Dr. Goel. And tomorrow, do you have a topic yet, or?
I will just think about it,
Okay.
John, and send you. Okay.
Okay, very good. Okay,
Okay.
thanks everybody for coming.
Thank you. Thank you. Bye-bye.
Bye-bye.
Thank you, bro. Thank you.
Thank you, Professor.
Thank you. Bye-bye.